All right, you're good. Can everybody hear me on the Zoom? Brandon, can you wave or something for us? Oh, awesome, perfect.
Yeah.
Everybody can hear you now, though.
Thank you so much, Elia, for helping me.
Make it big.
So,
And can you guys see the PowerPoint slides? Yeah, everything looks good.
perfect. Okay, guys, welcome to the first session of the perioperative medicine. We've been talking for this about a long time. Unfortunately, it's not part of the training system to, to learn about perioperative medicine or even to practice perioperative medicine. So unfortunately, even for us right now as internal medicine team, we should be the one handling the perioperative consultation and stuff, but we don't. Most of the time, all the consultation, surgery, they will just refer to cardiology to do like, the cardiac clearance. Right, so I thought it's a good opportunity. Let's, I'm educating myself, I'm learning about it myself. We're gonna just learn all together. At least as internal medicine team, we should be aware about, basics of perioperative evaluation. So if it happens and at some point we may be the one doing the perioperative clearance for the surgical teams, we have to know the basics about it. Also, what I've learned recently that in the board, there is so many questions about perioperative medicine. So I think it's like a growing field. We have to be, aware of everything happening, at least like practical wise and board wise. Okay. So I'm trying to cover throughout this year, like a couple of topics covering the cardiovascular system, respiratory, hematology. So I'm trying to cover as much as we can. I think we have it's going to be like once a month for maybe 4 or 5 sessions. The last session, I'm planning to do it in June, so at least we can wrap up, and it's going to be like questions for the third year resident, just like it's going to be board style kind of questions. We're trying to wrap it up. Okay. So today we're going to focus on basically the perioperative medicine for non-cardiac surgery assessment, okay? Focusing on the cardiovascular system. So the most important of all, as a physician, as internal medicine resident, if you get a consult from ortho, for example, to evaluate a patient, our job is go and to collect very good, thorough data. This is very important. The HMP is going to be very important. The first step we have to take when we're evaluating this patient. After doing that, then it depends on the surgery. We're going to find out about the surgical risk factors for this specific surgery, and then clinical risk factors regarding the patient's risk factor medically, right? After that, we're going to come up with like risk stratification and calculation based on that medical risk factors, surgical risk factors for the patient, and then give, about mortality, morbidity, stuff like that, recommendation. After we finish this, then we're going to be approaching or managing this patient, and we're going to define what do we mean by perioperative cardiac evaluation. Also, there is guidelines regarding perioperative cardiac testing, and then medical therapy, and then management of cardiac implantable devices. These are the objectives for this lecture. I'll try to cover as much as I can. Hopefully we can cover it all, okay? So what do we mean when you get a consult about perioperative evaluation and management? I mean, what do they mean by that? They mean that we need to pre-op optimizing the medical management for the patient if needed. And then they need also like a perioperative management before, during surgery, and after surgery. This is what we mean by perioperative management, okay? So when they ask about this, they basically asking you, what's the cardiac risk of this patient going to this surgery? And this is what you're going to hear it a lot about MACE. What MACE mean is like major adverse cardiac events. Okay, so all you're going to see, all the calculators and predictors are talking about that MACE, and this is what we mean: major adverse cardiac event. That's basically talking about MI, right, during surgery, perioperative time, heart failure, ventricular fibrillation,
cardiac arrest, complete heart block, and cardiac death. So we're talking about major cardiac events, okay? And all that we're trying to do in this assessment to prevent this major cardiac events from happening, okay? So the question I want you to ask yourself, don't freak out if we get like, hey, it's like a femoral fracture. We have this patient has extensive medical history, coronary artery disease, congestive heart failure, this and that. She's on long list of medications. First question I need to ask myself, I go collect my data as I told you earlier. And then first question I'm going to ask myself, what I'm going to be doing for this patient, you know, if there is no surgery planned. Okay, so the same approach you're going to take it. If this patient is unstable, she's clinically sick, I need to stabilize, right? So the question, how I'm going to manage this patient if there is no surgery, okay? Then after that, you can plan your management accordingly. Does that make sense? Okay, so history, the most important part we're focusing on, you know, the comorbidities that will affect or may affect this surgery, you know, like in a bad way. So previous cardiac history, which is basically coronary artery disease, congestive heart failure, you know, and then question I'm going to ask the patient, okay, the patient will tell you I have congestive heart failure, diagnosed. The second question is going to be any workup has been done for this, you know, coronary artery disease or congestive heart failure. And then we're going to find out why that's going to be important. I'm going to ask about any intervention, stents, you know, like any cabbage done in the past. After I finish from collecting the history, now I'm coming to the most important part, which is the exam of the patient. So, sorry, the symptoms. The patient, does he actively have like any ongoing chest pain, any shortness of breath, any exertional dyspnea? And exertional dyspnea, you put like 2 lines under that because it's kind of basically it goes with cardiac symptoms, palpitation, diaphoresis, fatigue, and syncope. So you be very specific, getting your symptoms from the patient, and then you go and examine this patient. So a patient of congestive heart failure, so you want to make sure that he doesn't have like any S4, S3 when you examine them. You want to find out that the patient doesn't have like any crackles, suggestive pulmonary edema, no elevated JVP, and this is very important, right? And no cardiac murmurs that may, you know, complicate the procedure, okay? So this is your part, basically collecting information, examining the patient thoroughly, and then we're going to go to the next step. So what we're doing here, let me just, can I turn that up? So how I prepared this lecture, I basically followed the 2014 ACC AHA guidelines. Okay, so they came up with this like practical clinical guidelines produced by the task force. And also there is a 2014 European guidelines. They both evaluated the perioperative cardiovascular evaluation for and management for non-cardiac surgery patients. American guidelines, more conservative in the management and in lab, you know, getting labs, getting studies for evaluation. European guidelines, they're more liberal, getting like, you know, troponin, BMP, getting studies perioperatively. These are the main differences between the 2 guidelines. So, but American and European, both cardiology and anesthesiology society guidelines, they all based their guidelines on exclusion of active or unstable cardiac condition. They both agree on the main concepts, right? Determination of risk and complexity of surgical procedure. Again, we're going to go back to evaluation of the surgical procedure, and then, you know, functional status of the patient. It's very important, especially when that evaluation falls in that gray area. We're going to talk about it. And then also determination of cardiac risk factors. Okay. So this is just to refresh your mind about, you know, the level of recommendation and level of evidence. So when we say class 1, that means benefits outweigh the risk, and the treatment should be performed. Okay, because we're going to talk a lot in the presentation about class 1, class 2, And then when I say class 2A, that means it's reasonable to do this procedure or to do this test, or right. When we say class 2B, it may be considered. So basically, I mean, benefit equal a little bit more or equal the rest. So it can be considered based on the clinical situation. Class 3 should not be done. Okay. Class 1, do it. Class 3, don't do it. In between, 2A, reasonable, 2B can be considered. Okay. Because you're going to see this in the rest of the presentation. So when we come to the surgical risk, they always ask a specific question, this patient going for this patient going for cholecystectomy. And so the surgical risk, they always falls between low risk, that means like less than 1% surgical risk, and high risk, it will fall like more than 5%. It depends on the surgery. In between that is going to be intermediate risk surgeries. So the low risk surgeries usually like superficial, like breast, dental, you know, stuff like that. Minor orthopedic surgery, intermediate and high surgery and high risk surgery. Usually it depends on the time, the blood loss, how close it is to the heart, like, you know, to the lungs. So these are the procedures, we define them as high risk procedures. But put in mind, for example, intermediate risk procedure, you will see here, for example, like cholecystectomy, right? So we know it's cholecystectomy is going to be just like, you know, laparoscopic cholecystectomy, but when the anesthesiologist and the surgeon consent the patient, they consent for both if the, you know, the endoscopic cholecystectomy did not go well, we will proceed with open surgery lap chole, right? So in this situation, you always have to prepare yourself and just do your recommendation based on the worst case scenario. So in this setting, the cholecystectomy here may fall under the high risk, right? Based on the situation. The same thing, like for example, here, what we have, orthopedic surgeries. I mean, sometimes they just plan, or maybe like spinal surgery, they may plan for like minor, you know, procedure, but again, they're going to consent the patient. If it's not work, we're going to open up and do it like, you know, an open procedure. So in this setting, you have to prepare yourself for the worst case scenario and manage the patient accordingly. Okay. So now we know low risk procedures, less than 1%, high risk, more than 5%. In between, these are the intermediate risk procedures. Okay, so now coming to the clinical risk factors for the patient. We talked about the procedure risk factors. So coronary artery disease, as we say, it's one of the major risk factors for the patient, okay? So if the patient have history of MI, it's a predictive of MACE, which is, we said, it's a major adverse cardiac event, okay? If the patient has recent MI, and how they define that recent MI per guidelines, they defined it by 6 months, okay? So it's another like independent risk factor for the perioperative. Let me see, put this here. Sorry? Yes, please. Just like taking some of them. And also, you know, after MI, they always advise if we can at least wait for 60 days, and we're going to find out why they specify that 60 days specifically. Yeah, thank you so much. Appreciate it. Can I also
Yeah. It will by itself.
Okay. So basically, these are the coronary artery disease. Patient had that. I have specific question for him. Did you have that MI in the last 6 months? Okay. And then I'll try if he did have MI recently, like within like less than six months, there is a couple of stuff we need to do, right? So there is so many studies. It showed that perioperative MI, you know, it decreased substantially when the length from the time of the MI happened and the operation. And the studies show that, for example, if you wait for 30 days, their risk of having MACE, which is major adverse cardiac events, is going to be 32.8%. This is a huge percentage, like close to 40%, right? If you wait for like 60 days, that risk percentage will drop significantly to 8.4. If you wait for that 6 months specifically, it will drop to 5.9%. But sometimes we don't have the luxury to decide when, for how long we should, hold the surgery. It depends on urgency, emergency situation, right? But and also it's not just affecting the cardiac events. It will also, decrease the 30-day mortality rate by waiting for, if we're able to wait for at least 60 days, or if we're able to wait for the whole, time, like 6 months after the MI. So basically, but this risk is modified by the presence and type of coronary revascularization. Is the patient had CABG? Has the patient had stent opening up the affected vessel? Okay, so, and then we're gonna go to the second, hopefully, second risk. Okay. Yes, going to the second risk factor for the patient, which is congestive heart failure. Okay. So again, as we said, like heart failure or history of heart failure, it's a significant risk for perioperative cardiac complication. Okay. So signs and symptoms of decompensated heart failure carries a higher risk, but severely affected ejection fraction less than 30%. It's kind of a different independent risk factor for perioperative complications. So they said the absolute mortality rate is worse with, ejection fraction less than 30%, but the same for patients with HFpEF. Again, they have high mortality rate in comparison to the population, but it's not as high as patients with HFrEF, okay? So they said here, if the patient is decompensated, may need to delay surgery. Basically, considering these two risks, so it's part of the history that the patient have coronary artery disease or have congestive heart failure. So my job as a physician evaluating this patient, yes, I know this is in the history, but clinically right now, how is the patient doing, right? Is he actively decompensated? This is going to change the plan a little bit. If he compensated congestive heart failure, we may not need to do anything about it. He is stable. Same for coronary artery disease. I mean, if he's not symptomatic, if he's comfortable, we may not need to do anything about it unless that recent MI per definition within 6 months. Okay. So then we're going to come to the third risk factor, and it's beautiful. Cardiomyopathy is always like sucks, it's just like it's completely, it's a beautiful pathophysiology, but it can be a little bit confusing. So for us as a physician, a patient have a history of cardiomyopathy, we have to make sure which specific cardiomyopathy, because based on that, we need to judge the management of the patient, okay? So for example, restrictive cardiomyopathy, this is most, like sarcoid, hemochromatosis, and then amyloid. So this patient, usually their cardiac output in this patient, it will depend on both preload and heart rate. Okay, so knowing this is a pathophysiology, you want to make sure that you're not affecting the preload and you're not interfering with the heart rate of this patient, because this is their way of compensation. Okay, so this will just judge how I'm going to use the medications, about fluids. And so these are the patients you pay attention, because any significant reduction of the blood volume or the filling pressure for the ventricle, any Brady, tachy arrhythmia will disturb that compensatory mechanisms. This will not be tolerated well during the surgery, okay? And then we come to the second, hypertrophic obstructive cardiomyopathy. It's decreased systemic vascular resistance, like any vasodilatation, volume loss, reduction in the preload, or left ventricular filling may increase the, the degree of the dynamic obstruction, right? So that's why, and any further, decrease in diastolic filling and cardiac output will potentially, affect this outcome poorly. Okay, so in this setting, we should avoid over-diuresing, because as we said, these are the patients depend on preload, right? And based on that preload, the filling, the diastolic filling, and based on that, is going to be and also the peripheral resistance. We don't want any vasodilatation of the peripheral resistance. Otherwise, you know, you're going to affect the pumping, the cardiac output. So this is a setting you will be very conservative in diuresing. You don't want to over diurese, and also you want to avoid like kind of the inotropic anything or chronotropic anything will affect the heart rate of the patient. Okay. So, and then we're going to come to the arrhythmogenic right ventricular cardiomyopathy, okay, or dysplasia. So this is the patient, it carries high mortality rate, like 9.5 mortality rate. So here, you know, they emphasize on the importance of the close perioperative, you know, monitoring, cardiac monitoring, basically for any ventricular arrhythmias, okay? And most of the patients, sometimes they need to be evaluated by EP if they recommend this patient needs ICD before surgery. I mean, the good thing, hopefully we're not the one managing this patient when it comes to a complicated case like that. Cardiology should be the one advising accordingly. And then rarely we see the peripartum cardiomyopathy. It usually happens in like, you know, we know the last few months of pregnancy, and it may last like for 6 months postpartum. And it's a rare cause of dilated cardiomyopathy. Okay, so usually it's acute and critical ill patient with refractory cardiomyopathy may require mechanical support, you know, for the heart and with intra-aortic balloon pump and maybe, you know, the extracorporeal membrane oxygenation, ECMO, okay? And then continuous flow for the left ventricle. It's a little bit, yeah, complicated, but hopefully we don't deal with this kind of situation when it needs an active cardiac intervention. Okay, guys. So then we're gonna come to, oh, so you don't even see the heading. Sorry, can I take that? It's not moving. Okay. So this is valvular heart disease. Sorry, it's been like blocking the heading all the time. I didn't know. I thought it's just for me. I cannot see the. Okay, guys. So valvular heart disease, it's another risk factor for the patient. So general concept, left-sided valves worse than the right-sided valves, okay? Stenosis, it's way worse than regurgitation and the management, okay? So for example, like mitral stenosis is gonna have more issue than tricuspid, you know, regurg. So, and in this situation, we have to avoid any hemodynamic instability for the patient. So blood pressure is gonna be very important for us. Heart rate is gonna be very important for us, right? And also in certain surgeries, there's volume shift, you know, with administration of fluids. This is something we have also to put in mind. So for example, like in severe cases, aortic stenosis consideration will be like balloon of the aortic valve or TVAR, AVAR, you know, mitral stenosis also sometimes during surgeries, if we're expecting like high risk surgery and there's a lot of fluid shifts and hemodynamic instability, they may consider also ballooning the mitral valve. Sometimes they consider like, you know, invasive hemodynamic monitoring, and especially in mitral stenosis. And sometimes, and we're going to talk about this when we come to like, you know, cardiac testing before the surgery, sometimes they may consider doing the echo before and after just to evaluate about the progression of the situation. These patients, because of how sensitive the management on them, sometimes may consider admitting them to CCU before and after surgery. Okay. Guys, it's a little bit, it's a tough topic. If you have any question, you know, in between, just don't you know, hesitate to interrupt me. Okay. So arrhythmias and conduction disorders, okay? So usually we know arrhythmias, it's more common in older patients, you know, and it's like, in the past, they were thinking about it as like an independent risk factor during surgery, but then that was in the original cardiac risk index, but then studies have been done, and it indicated it has a lower level of risk. What I mean by that, it doesn't mean that the patient, he's not going to be at risk of having arrhythmias during surgery, but he's not going to be at risk of having adverse cardiac event that included in the MACE, like MI or like fatal arrhythmia, cardiac arrest, or death. Okay. So ventricular arrhythmias like BVCs, non-sustained VTAC, they did not require any therapy unless they have hemodynamic, influence on the patient instability or compromise. So, or if they're associated with structural heart disease, in this situation, yes, we need to address them before surgery. Otherwise, if the patient is hemodynamically stable, no structural heart disease, we may not need to address that before surgery. Okay. Of course, complete AV block. You don't want to take any risk with these patients because it will increase the operative risk and for complications. So that's why these kind of patients may need temporary or permanent transvenous pacing before surgery. And this is when you get your EP friend to help. Okay. So if the patient has like pre-existing conduction disorder, like sinus node dysfunction or AV block, the only thing when we know about this, we want to be like very careful and conservative in beta blocker usage perioperatively. Okay. And then in general, they're talking about, and everything I said here, it's coming from the guidelines, the ACC guidelines. So arrhythmia in general, if we feel that the patient has like more frequent arrhythmias perioperatively, and then usually we try to figure out what's going on. Okay, because even for us as a physician, we don't feel like say, oh, this patient with this frequent non-sustained VTAC or sustained VTAC going to the surgery, you need to rule out like any underlying myocardial ongoing ischemia, myocardial infarction, what you can fix before the surgery. Okay. Okay, so now we're done covering the surgical risks, right? Depends on the procedure. We're done covering the medical risks regarding the patient, covering coronary artery disease, congestive heart failure, arrhythmias, and then valvular heart disease, okay? Now, we're gonna come to the point we need to do the risk stratification for this patient based on the information we have. HMP, right? Surgical risk, medical risk for the patient. So, we need a validated risk prediction tool to use. The most commonly used one is a revised cardiac risk index, the RCRI, okay? So it's, and we're going to talk about it separately. This is a commonly used. And then the American College of Surgeons, they decided to come up with like a national surgical quality improvement program, which is, you hear about this NSQIP score or tool, okay? So this tool, I'm going to talk about the RCRI later, but the NSQIP, it has 21 patients specific, okay, variables, including age, the ASA, this is like the anesthesia society, American anesthesia of Society of Anesthesia class. They have their own class for like the, the assessment, and then also like preoperative functional status. So it calculates the risk of MACE, all of them, all these tools are calculating the risk of MACE. And also it calculates the plus MACE, it calculates the risk of death and other outcomes like strokes and stuff like that, which is not calculated in the RCRI. So this is maybe an advantage, but it's a very detailed, tool. And also, again, the American College of Surgeons, they developed the NSQIP, but in this time they specify MICA, which is abbreviation for myocardial ischemia and cardiac arrest, specifically cardiac arrest. And here in the MI, it's not just like they're talking about ST segment elevation. They're talking about new Q wave development. They talk about troponin being almost like 3 times the normal, okay? So it's like a serious STEMI. This is how they define the MI. And cardiac arrest is like cardiac arrest requiring like, ACLS kind of, interference. Okay. So the advantage of this plus the NSQIP, the original one, they added to that like long list of surgery. So it's going to be like a surgery specific risk plus the NSQIP. Okay. I feel that you guys are lost. Are you with it again? So as I said, I'm trying to cover basics. Myself, I used to, so go ahead.
So I guess my
Tana.
question is, I guess the way I've done it, I've just picked one and I use that every single time.
And
How you would recommend, or
that's a good question. That's why we came up with all this lecture, just to teach ourselves which one to use when. As we said, the RCRI, the one commonly used, couple of situations they don't recommend it, and we're going to talk about that, but other than that, it's the one well validated, mostly commonly used, and it's been like there for decade, it's like more than 15 years. But in certain situations, we may need to use like different tool. Okay.
actually, you can talk about like what's the recommendation that the output that we're supposed to provide is somewhat unclear to me sometimes. Like, I mean, obviously you can calculate surgical risk, but it doesn't necessarily answer the question should they get surgery or not. And I rely a lot on the surgeon, their knowledge of the procedural risk, and so I guess I'm a little unclear what exactly I could do this with and ask about symptoms. Say, okay, here are risk factors, but also be helpful to me to see what exactly is my job to say, no, I do not recommend surgery.
Yes, exactly. And this is, again, this is one of the purpose of this lecture. We're going to go over like at the end. So right now we're addressing each risks separately for us to take that decision. Okay. Then we're going to come at the end to tell, oh, this is like high risk procedure for high risk patient. We'll recommend to halt. We recommend to delay, and there's certain situation we have the right to do that as long as we're the one, evaluating that patient. And that's why I want you guys to have the base about what we're doing, if we're going to be doing it in the future. And sometimes we do it, right? But it's like most of the time it's like minor procedures. So, and I want you to know what the guidelines, level of evidence, level of recommendation is going to be, about each situation. So right now we're covering the cardiac risk, right? And then I'm going to go to like testing. I'm going to go to medications, how we're going to managing, and we're going to go to like the ICD or like any cardiac implantable devices. We're going to discuss all of that separately to have the base, the knowledge, and then after that, we're going to come to how we're going to recommend or don't recommend the surgery accordingly. Okay, depends on the risk. Okay, so as we said, the revised cardiac risk index, this is the one we're using commonly. It's like there for like a long time. It has 6 predictors. Risk for major cardiac complications. So that's why if you can see here, it's easy to use, right? It's basically each of them, this 6 has 1 point, okay? So any history of CVA in the past, give you 1, congestive heart failure, 1, kidney function. So diabetes, which is equivalent to like coronary artery disease thing, it will give the patient 1. Ischemic cardiac disease, you're going to see that there is just a difference here between this tool and the other, the one developed by surgeons. It's basically the vascular procedure. It was just given 1 regardless. It's like they put the suprainguinal vascular surgery, intrathoracic surgery, or intra-abdominal surgery. Like they put them on big categories and they put it 1. So this is the difference here is obvious between this one and the one developed by surgeons, because that one based on the type of surgeries. So it's going to be very specific for this surgery, the mortality rate and the morbidity with that specific surgery. But here, that's the one we're using.
And the RCRI doesn't differentiate, like congestive heart failure doesn't differentiate between decompensated.
Exactly, it doesn't. It's just like, decompensated or compensated heart failure. Go ahead, Josh, do you have a question?
Yeah, how does diabetes require insulin?
They did. Can you? Just the last part, I did not.
So if we have a patient
Mhm.
who comes in, they are on oral glycemics and their ANC is not controlled, or it's not above 11.
Mhm.
Would that categorize as requiring insulin, or because they have to want insulin versus someone who may have diabetes with the same level of glycemic need medication,
Mhm.
but be on it. So I guess I'm a little hazy about that threshold.
Yes, that's a good question. I'm not sure if I have the correct specific answer, but it makes sense if somebody needs to be on insulin, and the physician or the patient decided not to put the patient on insulin. It doesn't mean that he shouldn't be like an insulin under the insulin dependent category, So I don't have a like clear answer for this, but I would go for that patient as if he should be on insulin. But I mean, his physician or the patient decide not to be on insulin based on A1C. But this is just the common sense answer, but I'm not 100% sure if the guidelines have anything specific in that part that I did not come across. Okay.
Has to do with the degree of some degree of glycemic control with the severity of the diabetes.
I guess so, because in diabetes, and you always see that they always put diabetes regardless in general in other scales, regardless of it's like insulin dependent, non-insulin dependent, they always put it with coronary artery disease, cardiovascular disease, like equivalent head to head, because of it increased risk down the road, right? So I would patients with uncontrolled diabetes, even if they're on oral hypoglycemics, their A1C is like 11, I'll just give them the higher risk that like the patient should be on insulin. Because in my mind, this patient, they should be on insulin, right?
Absolutely. I guess like
Did that answer your question, Josh?
That did. So that did for someone who's on oral glycemics, absolutely. But if they're on oral glycemics that may not be optimized, is 8.5.
Okay.
Like if they were optimized, could they have good glycemic control? Then they did not use insulin, or maybe even with optimal medical therapy, they should be on insulin.
Right.
And I guess they would be insulin dependent, but that's something that would require time that's not necessarily available in the perioperative setting.
Mm-hmm. Yes. And in general, as we always say, guidelines are guidelines, right? So, but
At the end of the day, they're still gonna operate on this person if they were bouncing around on it.
exactly. I mean, it's gonna be just increase it 1 or decrease it 1 point, right? Based on the risk, the cardiac risk, it wouldn't change. But this is a good question, because in the outpatient setting, and most of the time elective surgeries, and we're gonna talk about this, it's not like necessarily need to be evaluated inpatient. This is going to be an outpatient evaluation, and this is the population we're dealing with the most are diabetic patients. So we have to make sure that to calculate to include that or not to include it in the risk stratification. And the good thing about this index, we can use it, as I said, inpatient, outpatient, it shouldn't be a problem. The downside of that, though, the RCRI, it's not well studied in emergency situation. So, and they said, like, you use it with caution, and when it comes to emergency surgery, and also when it comes to vascular surgery, you use it with a little bit of a caution, okay? So in general, sorry, going back here to the RCRI. So basically 0, it's like low risk, 0.4% of risk, which is, we mean by that risk is MACE, right? The major adverse cardiac event. So, and then more than 3, it's high risk. They say more than 11%, and in some, like in some literature, they say more than 5. It's a high percentage of developing MACE or cardiac complications, post-operatively. In between is going to be the intermediate risk, and this is going to be the gray area. We're going to talk about it. Okay. So it's clear, straightforward situation. You have low-risk patients based on that score, and that score, actually, you're going to put all the information you obtained from the patient in that calculation, right? Low-risk patient, you proceed with surgery. No further workup needed, okay? If, this is score, it comes to me like 1 or 2, 0 or 1, I have no problem proceeding with surgery regardless of what the surgery is, if the patient is stable, okay? So then we're gonna go with a high risk patients. These are the patients you need to stabilize. That's what we mean by high risk, like unstable coronary artery disease, patient is having ongoing chest pain, you saw that patient, obviously he's huffing and puffing, requiring oxygen, pulmonary edema, basically decompensated heart failure, or he have like high grade arrhythmias. In this high grade arrhythmias, we're not meaning like SVT or like stable SVT, or like meaning, sinus tachycardia, or high grade arrhythmia like block, AV block, like unstable VTAC or stuff like that. Any hemodynamic instability, it will not go well during surgery. If the patient is tachyarrhythmic, bradyarrhythmic, having hypotension, will not go well. These are the patients you want to stabilize them before sending them to the surgery. Or they have significant valvular heart disease, needs to be addressed before the surgery. Meaning by that, it's not necessarily like operation. They may operate on these patients if they do have an elective surgery. We still have time. They still can consider that, but we need to stabilize this patient before we send them to OR. Okay, so now it's clear. Low risk, proceed with surgery. High risk, you hold on the surgery until you're stabilizing the patient. That being said, we're going to be more specific in a diagram later. Okay, now we come to the patients with, just a second, let me get rid of that. Okay, I'm going to keep moving. Now we come to the patients with moderate risk. Okay, in between that 0 and 1, and more than 3. In between that moderate risk patients, how we're going to decide about these patients? This is here where it needs like some of clinical judgment and some extra factors to tell me which route to go, proceed, not proceed, or what I need to do, okay? So the moderate risk patients, this is where here the functional capacity comes in, okay? So I have intermediate risk patient, I don't know where to go, I need something to tell me. So here we're gonna decide about, we're going to evaluate the functional capacity of the patient. So all guidelines agreed that at least the patient, to be safe, we need at least 4 METs, which is a metabolic equivalent. What does that mean? That the patient can like climb 2 flights, he can, off stairs, he can go for like 4 blocks, So simply by this activity, we give the patient METs of 4. And at this situation, it's class 2B, that means it's reasonable to operate in that patient, right? If the patient, so he's in good situation. If the patient have more than 10 METs, excellent situation. And this, 2B, we may consider, right? And then 2A, excellent METs, this patient, it's reasonable to proceed with surgery, okay? If you have poor functional status, or you don't know what the patient is doing because the patient has like rheumatoid arthritis, severe, joints problem, never been exercising or walking because of the pain, holding her or holding the patient from doing activities, these are the categories we may consider pharmacological stress testing. And why we're doing that, basically we're trying to put them under some sort of stress similar to the surgical stress to see how they're doing, okay? So kind of just evaluate their functional status or their heart, how it's doing in this kind of a stressful situation may be similar to the surgery. So that's why they suggested using dobutamine stress echocardiography. Okay, so it should be considered. Actually, all guidelines they consider it is like the most physically close to the stress during surgery. Okay, so and there's large studies reporting the value of the dobutamine stress echocardiogram in the prediction of cardiac events during non-cardiac surgery. Okay, other option we can go with myocardial perfusion imaging study, but if the okay, so this is here. Okay, basically we know METs 4 may consider to proceed with surgery. METs more than 10, this is excellent. You know, it's reasonable to continue with surgery. In between, or we don't know how is the patient, it's not in between, but we don't know the patient functional status or poor functional status. This is a situation where you consider your pharmacological stress testing. Okay. You
Why not exercise?
fantastic, and that's what I was about to say. If the patient can exercise, go ahead and do the exercise stress testing. But as I said, it just like they found that the dobutamine is kind of more close to that. But I would go with a stress testing, you exercise stress testing if the patient can. But they here specify that if it's unknown functional status because the patient cannot exercise, these are the options you can use. Also, they developed the scale. It's called the Duke Activity Status Index. If you feel comfortable calculating that and see that in numbers, not just based on the patient activity, you can do that and you can have it here. And this is DASI, which is a Duke Activity Status Index. Basically, you ask the patient, can you take care of yourself, eating, dressing, stuff like that. So you calculate the score and then you come up with a functional status based on the score. If you feel more comfortable doing the Duke Activity Status Index. Okay, this one. Can I minimize it? No, I can't. Okay. So basically this diagram, this is what we're talking about earlier. You know, that's what you asked about, which is for surgery, what I need to do. Now I get all the information about the medical history about the patient, medical risk factors, surgical risk factors. Now there is going to be what kind of surgery we're going to. There is emergency surgery, urgent surgery, elective surgery. How they define that? They said emergency surgery, that means to be done before 6 hours. This is right now. You know, you don't have time to do anything. You have to use your judgment, use the data you're having and decide. Okay. Most of the time they don't even wait for you because emergency is emergency. That surgery needs to happen. It's going to happen. Urgent surgery. So we have to be familiar with this. Urgent, it's 6 to 24 hours. So you may have that time frame to do anything if needed, or if it's going to change the management of this patient. Elective, it can go up to 1 year, you know, and this is most of the time, these are the setting, it can be evaluated outpatient and sent to the elective surgery, okay? So here, if I can see that well, so if it's emergency, right? And then if it's emergency and then you go ahead and just do your clinical risk stratification as we said, and then basically, you know, this patient is going to proceed with surgery. If it's not emergency, then you're going to check if the patient have, we're talking about cardiac patients. If the patient have like any ACS, that means the patient is symptomatic, not symptomatic, is stable, unstable. If the patient, yes, have ACS symptoms and signs, then basically you want to evaluate and treat according to the goal-directed medical therapy. If they don't have that, basically you estimate the risk and then you proceed with surgery. You estimate the risk. The patient is low risk, which is we define that less than 1%, no further workup needed, you proceed with surgery. The patient is high risk, okay? So maybe in this situation, you want to decide about the meds. If the patient's functional status is good and no problem with that, like excellent, no further workup needed, you proceed with surgery. Good, the same thing, no further workup needed, proceed with surgery. And both of these like class 2A, which is reasonable, and then class 2B, which is can be considered, okay? But if the patient is at moderate or high risk, right? Oops. And then the functional status is poor. Okay, and this patient, as we said, this is when you consider the pharmacological stress testing. Okay. And then you proceed based on that, you know, the pharmacological stress testing. If it's like the patient is not at high risk, you proceed with surgery. If is at high risk, you hold until you stabilize the patient and then proceed with surgery. So bottom line here, it all depends on how emergent the surgery is, right? And based on the cardiac risk stratification, the medical risk, you will decide. Low risk, go with surgery. High risk, stabilize the patient. In between, check the functional status. Excellent, good functional status, proceed with surgery, right? Poor functional status, you go with dobutamine or like pharmacological stress testing. Based on those, low, high, you proceed or you hold on surgery.
And everything we're talking about is non-cardiac.
Non-cardiac surgery. Yeah. Because when it comes to cardiac surgery, they're not going to consult us anyway, right? But it's not, it's just like non-cardiac surgeries. Is it clear, like the general outlines, guys? Okay. It may be confusing now, but the more we use this, the more we practice, is going to be like just like diagrams we're going to follow. And yes, it has a lot of like, although they develop this like tools and, you know, and the scoring system, but at the end, we take it case by case. As we said, guidelines are guidelines, but at the end, as physicians, this is where we have to take it case by case and make our clinical judgment in most of the situation. Okay, guys. So we have until 1 o'clock, Tina. So I'm left with the testing. Let me see if we can just stop here and do the questions if we need. Yeah, we still have many. It's not gonna be. Okay, so what we are left with. So right now we covered evaluation of the patient, considering medical risk factors for the patient, surgical risk factors for the procedure, risk stratification tools we're using or we may be using down the road, right? And then after that, how we can also, based on that functional status, when we add this or we look at this and the patients in between that we don't know if they're high risk or we know they're not a high risk and they're not a low risk. These when we consider the functional status. And the functional status, if we don't know how they're functioning, poor functional status, we go with pharmacological stress testing. In general, and based on the surgery, emergency, urgent, or elective, also that's gonna add to our decision in this situation. We're left with perioperative cardiac testing, that including, is it indicated to get like an EKG, you know, is it indicated like to get a stress test, you know, cardiac catheterization, troponin, BMP, what the guidelines say about that, American guidelines and European guidelines, okay? After we finish all that, then we're gonna come to medical management. So patients of cardiovascular disease, they have long list of medications, right? How we're gonna manage these medications. We're going to talk about beta blocker, ACE inhibitor, ARB, you know, like antiarrhythmics, stuff like that, how we're going to address medications, right? Because right now we clear the patient for the surgery. We need to manage medications. After that, the last thing we're going to discuss is about devices, pacemaker and ICDs, how we handle these devices during surgeries, and what recommendation we're going to give for the surgeons. In general, when you read about guidelines, it's a multidisciplinary discussion, right? And also part of the medications we're going to discuss, I forgot, if the patient on like dual antiplatelet therapy, if the patient is on anticoagulation, what are the recommendations and how as physicians we're going to address these. So I said in general, it's a multidisciplinary discussion. Usually we make the decision, but we want also get the surgeon input, the anesthesiology, what kind of anesthesia they're going to use for this patient. And in complicated cases, like for example, this valvular heart disease, you need to get the cardiologist involved about getting their recommendations as well. If it's like this arrhythmogenic cardiomyopathy, or like, patients needs like devices, this is when you need to get your electrophysiologist involved as well. Okay. So we're gonna stop here. Any question? Next time, how I'm gonna do it just to make it easier, and I was planning to do that at the end of this session as well, is just to bring a question, like a case, and then we're gonna try to apply the knowledge on that case. What we're gonna be doing, I think this is gonna be more like getting an idea about how we're gonna manage like scenario. Sounds good? Okay, guys, if you have any questions, it's a learning process for all of us, but I think by the end of this year, we're gonna master it, guys. Thank you so much. Appreciate you. So, Tina, how we stop the recording? Recording.